Hi all, welcome to Raaonline. Today we are going to deal with one interesting topic, that is difficult separation from cardiopulmonary bypass. Actually, in difficult separation from cardiopulmonary bypass, the experience of the anesthesiologist, cardiac surgeon and perfusionist will come in handy. The topic doesn't only start with difficulty. Here the definition itself is difficult because we have to look at the arterial pressure, we have to look at the cardiac index, you have to look at the filling pressure, that is central venous pressure, your echocardiographic finding, the amount of the vasoactive drug which we are using, subjective intraoperative assessment of the left ventricle and right ventricle contractility, the need to return to cardiopulmonary bypass and use of mechanical device to wean from cardiopulmonary bypass. So many variables are involved in difficult separation. So it is difficult to define a difficult separation. The various terminology which is used for difficult separation are return to cardiopulmonary bypass, post-operative hemodynamic instability. That means your hemodynamic is unstable after cardiopulmonary bypass, heart failure developing after cardiac surgery, post-bypass inotropic support, low cardiac output syndrome and positive inotropic dependency. These are all various terminology used for difficult separation from cardiopulmonary bypass. There are three different types of weaning from cardiopulmonary bypass. Fortunately for us, 60 to 70% is easy weaning. Here, there is no support required or one vasoactive agent might be required. That is easy weaning. Next comes the difficulty or pharmacological assisted or medical weaning. This forms about 20%. Here, you require more than 2 inotropic agent. Third is the complex weaning. Here, the first weaning process has failed and patient requires some form of mechanical support to wean from cardiopulmonary bypass. This is called surgical weaning and it forms about 10 to 15% of the weaning. So, what is the timeline of the difficult weaning? Initially, you start an inotrope, the pressures are not holding, you go into cardiopulmonary bypass, then try to wean with mechanical supports like IABP. If still IABP is not working, we go for LVAD and ECMO. So, the case which is started at 7 o'clock in the morning goes up to evening 5 p.m. Why this difficult weaning or difficult separation is happening? When you put the patient on cardiopulmonary bypass, there is an insult to normal physiology via anticoagulation, hemodilution, catecholamine release, hypothermia, you cardiac arrest the patient, vasopressin release, there is electrolyte disturbances, complement activation and even platelet activation. This all physiological disturbance will lead to what is called systemic inflammatory response syndrome. Normally, when you put the patient on cardiopulmonary bypass, there is a transient decrease of left ventricular activity which lasts for about 6 hours post cardiopulmonary bypass. This is because of this physiological insult. But after 6 hours, this LV function will return back to normal in most of the patient. But if the left ventricle function doesn't return to normal, this is the red line, your weaning becomes difficult. As difficult weaning progresses, there is all your volume parameter and pressure parameter will increase and your ejection fraction, which is green in color, will come down. Your left ventricle is going to be affected even more. What are the causes for difficult separation from cardiopulmonary bypass? When there is increasing aortic regurgitation, tricuspid regurgitation, emergency surgery, a tight aortic stenosis and blood loss during cardiopulmonary bypass. This difficult separation becomes complex when there is a recent myocardial infarction, associated MR and decreased left ventricular ejection fraction. and this leads to mortality when there is renal failure, lot of diuretic usage, anemia, elderly patient and increased cardiopulmonary bypass duration.